All right, today we're playing detective. We're on the case of a really common but super tricky medical mystery. I'm talking about that stubborn pain, the one right behind the knee.
I mean, have you ever had that nagging, kind of hard to pinpoint ache that just won't go away? You know exactly how frustrating it can be. It's the kind of pain that makes walking downstairs or even just a light run feel like a huge challenge.
So let's dive right in. We're going to investigate what doctors call popliteal tendinopathies. Yeah, it's a mouthful. Just think of it as our official case file for today. We're going to uncover the suspects, we'll examine the evidence, and then we'll lay out the path to finally cracking this case. Okay, so our investigation really kicks off with a simple question. What is this mysterious pain? And maybe more importantly, why is it so darn hard to diagnose? First things first, let's get our terms straight. You'll hear this word, tendinopathy. Now, this isn't just simple inflammation, like a tendinitis. It's a much bigger umbrella term for when a tendon gets chronically damaged, usually from overuse. The best way to think about it is like this. Imagine a brand new super strong rope with all its fibers perfectly parallel. Now picture that same rope after years of heavy use. It's frayed, it's disorganized, and it's weak. Well, that's pretty much what's happening to the collagen in your tendon, and that's what's causing all that pain and weakness. So what makes this a mystery anyway? Well, most of us have probably heard of jumper's knee, right? That's pain at the front of the knee. But pain at the back? That's way less common in the medical literature. And what that means is it can get misdiagnosed or even completely overlooked by doctors all the time. But hey, less common doesn't mean it doesn't happen. Not at all. Check this out. In a really fascinating 7-year study of professional dancers, tendinitis of the popliteus, and we'll get to that guy, he's one of our key suspects, it accounted for a whopping 16.6% of all their tendinitis cases. That is a huge number. It just goes to show you how significant this injury can be, especially for people who are really pushing their bodies, like high-level athletes. All right, to really understand the crime, we have to go to the scene, right? So let's take a look inside what's called the popliteal fossa. That's just the fancy name for the anatomical space right behind your knee. So the best way to picture the popliteal fossa is like a super busy downtown intersection. It's this diamond-shaped hub where all these major structures, muscles, nerves, blood vessels, they all cross paths. You've got the hamstrings coming in from above and the big calf muscles, the gastrocnemius, coming up from below. They kind of form the boundaries. And then way down deep, forming the floor of this whole area, is a muscle called the popliteus. So yeah, it's a really crowded neighborhood, which is exactly why figuring out who's causing all the trouble can be so tough. Okay, it is time for our suspect lineup. In any investigation, you've got to know the key players. And in this case, we've got 3 main muscle and tendon groups that we need to put under the spotlight. Suspect number 1, the popliteus. I like to call this one the unlock key of the knee. Why? Because its most important job is to start the bend in your knee when your leg is totally straight. It's that tiny but absolutely crucial first little movement that gets everything else going. Plus, it's a super important stabilizer, just doing its work deep behind the scenes. All right, next up in the lineup, we have the hamstrings. The best way to think of these 3 muscles, they're the brakes. So when you're running and you suddenly need to slow down or change direction, your hamstrings are working overtime to put the brakes on your lower leg. They are absolutely essential for any kind of powerful movement like sprinting and jumping. And our final suspect, the gastrocnemius. You probably know it as your big calf muscle. So if the hamstrings are the brakes, well, this guy is the gas pedal. It's responsible for that powerful push-off you need when you run or jump. And what's really important here is that the 2 heads of this muscle actually start just above the back of the knee, which makes their tendons prime suspects for any pain in this spot. Okay, so we've got our scene of the crime and we've got our lineup of suspects. So how do doctors actually piece together all the clues to make an accurate diagnosis? Let's walk through the investigative process. The investigation always starts by taking witness statements. In other words, listening really carefully to the symptoms. The classic story we hear is a slow, gradual ache that just kind of creeps up on you. The pain is usually worse during activities that really stress those tendons, like running downhill or going up and down stairs. Now, in more severe, acute cases, someone might even say they heard or felt a pop. Next up is the physical exam. And this is where a doctor really becomes a detective. They use their hands and a whole series of specific tests to see if they can recreate the pain. by putting your knee in certain positions like the figure 4 position, or by having you resist as they try to rotate your foot, they can actually isolate each of our suspects and see which one confesses, which one is the real culprit. But the real smoking gun is often found in the forensic evidence. I mean, what the tendon actually looks like up close. A healthy tendon, it's beautiful. It has this really organized, parallel, rope-like structure. But a tendon with tendinopathy, well, you can see it right here. It gets thick, disorganized, and just plain frayed. It can even develop these weird, new, abnormal blood vessels. It's a process called neovascularization. And the problem is, these new vessels are weak and they don't help you heal at all. In fact, they kind of just add to the whole mess. So to actually see these changes, doctors turn to imaging. An ultrasound is awesome. It's like getting a real-time video of the tendon. It can show if the tendon is thickened, if it has these hypoechoic or basically dark spots that signal damage, and if it's lost that normal, bright, rope-like pattern. Then you have an MRI, which gives you an even more detailed 3D picture. It can confirm all the damage and also check for any other issues going on inside the knee joint itself.
So, the case is cracked, the culprit tendon has been identified. What's next? Let's move on to the final and maybe most important piece of the puzzle, the roadmap to recovery.
Recovery is usually a pretty structured 3-step process. So, step 1 is all about load management. That's just a fancy way of saying you need to calm things down, modify your activities to give that angry tendon a break. Then, step 2 is all about rebuilding. You start with really gentle static exercises called isometrics, like just holding a slight knee bend. These are fantastic for reducing pain. From there, you gradually progress to exercises that strengthen the tendon while it moves and lengthens, like slow and controlled calf raises. It's this controlled lengthening part, the eccentric exercise, that really helps remodel those frayed collagen fibers back into that strong, rope-like structure. And finally, step 3 is all about refining your movement and getting you back to your sports safely. You'll focus on things like balance and control to make sure this whole thing doesn't just come right back.
Now, what about those really stubborn cases that just don't seem to get better with physical therapy? Well, don't worry, there are other tools in the toolkit. These can range from certain injections to help with healing, to things like shockwave therapy, which helps stimulate tissue repair, all the way to minimally invasive procedures or, in very, very rare cases, surgery. But honestly, for most people, that 3-step rehab plan we just talked about is absolutely the key to getting a full recovery. And really, that brings us to the most important takeaway of this whole investigation. As the source material really drives home, getting the diagnosis right from the very start, is absolutely critical. A correct diagnosis is the first and the most important step to a full and timely recovery. It's truly the difference between a quick fix and a nagging, chronic problem that just goes on and on. So, we'll leave you with this one final question. That persistent ache, that stubborn pain you might be feeling, it's not just random noise, It's a signal. And maybe the real mystery isn't just what's causing the pain, but whether we're willing to actually stop and listen to the clues our own bodies are trying to give us.